Antibiotic for abdominal sepsis. Major milestones in surgery have included sage suture to promote tissue integrity, cautery to minimize or avoiding the use of anesthesia, to avoid pain, and antiseptic to prevent operative contamination. In the antibiotic era, surgical procedures for sore, contouring, abdominal sepsis have been compared with drugs targeting persistent organisms after luminal inflammation, obstruction, or perforation. The appropriate duration of post-surgical antibiotic therapy has been unclear. However, it is shown the course will be desirable to minimize drug-related adverse events, the selection of antibiotic resistance of cause. In this use of the journals, they were college present that from the study of the optimization peritoneal infection therapy stopped the trial of short-course antimicrobial therapy for abdominal sepsis. More than 50% of patients from 2-3 institutions in the United States and Canada were randomly assigned to receive either a prescriptive regimen after sore control approximately 4 days, or a regimen for a longer duration to a maximum of 10 days pending the absence of signs of sepsis for 2 days. The main age of the patient was 52 years. In 34% of the patient, the infection originated in the colon or rectum. In 40%, it originated in the small bowel, and in 40% it originated in the appendices. A total of 11% of the patients had cancer, and 10% had inflammatory bowel disease, and 50% had underlying diabetes mellitus. Source control was achieved by means of percutaneous draining in 33% of the patients, by means of surgical resection in 26%, and by means of surgical drain alone in 20 and 21%. There was no between group difference in the rate of the primary endpoint, a composite of surgical site infection, recurring intra-abdominal infection, or dead whiting, and 30 days after the index source control procedures. This rate was 22% in both groups. An aging question is why more time and 20% of the patients in bowel growth had complications after treatment. Early in the 21st century, it seems likely that source control remains a considerable burden in treating abdominal sepsis.